I'm Dr. Schaal. I'm the Chief Physician Executive at Houston Methodist, and welcome to our webcast, Women in Surgery, where we highlight some of the best surgeons that we have here at Houston Methodist. All of them just happen to be women. And today, I have the pleasure to host our guest here, Dr. Laura Kim, and she is an ENT surgeon, ear, nose, and throat, and she specializes in head and neck cancer and reconstructive surgery. Welcome, Dr. Kim.
Thank you so much. It's really an honor to be here. Thank you so much for the invite.
So tell us, what is ENT?
So ENT, also named otolaryngology, head and neck surgery, is a specialty of medicine that looks after disease processes of the nose, sinuses, mouth, ear, throat. It's a wide field within a specialized area of the human body.
You know that we are kind of connected because in the past, ENT and ophthalmology was all together, and there's still, Mass Eye and Ear Hospital, New York Eye and Ear Hospital. So eye and ear in the past used to be together, but I guess now it's a whole new.
Exactly.
Now, not only today, but for the last few decades, it's specialized. And why is it so special? What do you actually do?
So within ear, nose, and throat itself, I subspecialize in head and neck surgery. So I take care of patients who have cancers within the head and neck region. I'll do surgeries that resect the cancer of the mouth, the throat, thyroid, salivary glands like the parotid gland, and I also do reconstructive surgery. So sometimes cancer patients after the resection are left with a large defect, so I'll help fill in that hole.
So you were actually double trained, both in otolaryngology and in plastic surgery? You can say that?
Not quite, but in some ways. So after my ENT residency training, I did a fellowship in head and neck surgery, which was 2 years, and 1 year I spent with the head and neck department doing resection surgeries, and the second year was with the plastics department learning reconstructive surgery.
So, many of our viewers are medical students, young medical students that are trying to figure out what they would like to be when they grow up. Why did you choose this field?
It was kind of a step-by-step process in many ways. I started medical school not really knowing what I wanted to do, and one by one I started eliminating things, and early on I think I knew I wanted to be a surgeon because I like working with my hands. And from there on I shadowed and explored and started ruling subspecialties out, and ENT seemed the coolest.
The coolest.
The coolest.
Second coolest after
we were together in the past.
But why is it cool? What's so cool about it?
It's I wanted to help people, and I think ear, nose, and throat is so special in that it helps people interact with the world. So it is a subspecialty that takes care of a lot of senses. The way you smell, the way you taste, eat, breathe, hear, and see in your specialty. And I think that is such a special and privileged connection that you can make with patients, and thought it was so special.
So now in this profession, there are people who specialize in hearing and kind of the ear, and people that are specializing in the mouth, and people that are specializing in the nose. So did you specialize in any one of these?
Right. So ENT on its own is such a diverse field. There are otologists looking at ears, rhinologists for the nose and sinuses. We have pediatric ear, nose, and throat surgeons and plastic surgeons within ENT as well. And there's also the head and neck specialty. So that's what I specialized in after my residency training. Looking after mainly cancer patients.
So when we say head and neck, it's mainly cancer. And what kind of cancer is that?
So for that, it would be mucosal tumors. So anything within the mouth, so buccal mucosa, tongue, palate, and then the nose, cancer, nasopharynx, oropharynx, throat, larynx, so the voice box, and also thyroid cancers, parathyroids, salivary gland tumors like masses within the parotid gland.
So all these cancers, the treatments are involving surgery, or there are cancers that there is only chemotherapy or immunotherapy in that specialty?
In most situations, surgery is still considered the first step, but we work we work in an interdisciplinary approach. So I work very closely with our radiation oncologists, medical oncologists, and oftentimes patients will need adjuvant treatment in the form of radiation or chemotherapy.
And how has this field evolved over the years? I know you're relatively kind of a fresh grad, right? 2.5 years out of your training. But what do you know about the evolution of that field?
Within head and neck surgery itself, I think the most big evolutionary event was the use of robotics in surgery.
Tell us a little bit about that. What do you use robots?
I do. So in oropharyngeal cancer, so that's tumors arising from the back of the throat, so the very back of the tongue, top parts of the voice or the pharyngeal area, tonsils, soft palate. Traditionally, those were treated mostly with radiation and chemotherapy because, as you can imagine, it would be very difficult to reach those areas for a good oncologic resection. However, now we can use robotics where there's specialized tools that allow us to reach and gain access to those areas. And it's actually very cool of a technology where a machine comes in, patient is in the operating room, and we're able to feed in small instruments through a single port so that there doesn't need to be a huge exposure to gain that access.
So you have cameras that you're inserting?
So there is a camera, there's small instruments that go in, and there's a control station that's within the operating room as well. The surgeon sits at the console and is able to move the robotic arms and the camera to change the view and work in a very tight, narrow space.
So how many years has that been in? Did you train like that?
It was starting to become the hot topic as I was starting residency, and it has gained a lot of momentum. A lot of surgeons and a lot of residents get experience with it, and it was certainly something that I learned throughout fellowship as well.
So you started without the robot and kind of converted into the robot, or you do both?
We do both, yeah. It's we'll determine prior to surgery whether the patient will be a good candidate or not, and if they're deemed a good candidate, then we'll proceed with.
So if you had to compare, the non-robotic approach with the robotic approach, what are the main 3 advantages of a robot, and then what are the main 3 disadvantages?
Right. So without the robot, simply we were not able to do a good surgery unless the surgery became very morbid. So traditionally, without the robot, we would have to do a mandibulotomy, so splitting the jaw open to gain access to the back
just to get to see it.
Exactly. So as you can imagine, very morbid. Or in those patients, they would have to undergo radiation and chemotherapy, which on itself can come with a lot of side effects. So I think those would have been the disadvantages. And in a lot of cases, these patients are able to avoid radiation or systemic treatment altogether. So I think that's a huge win for the patient, not in terms of long-term outcomes with swallow, speech, dry mouth, all the side effects, but also the treatment course is much shorter.
So you mentioned good candidates and not good. What is a good candidate for robotic surgery?
Right. So usually early stage oropharyngeal tumors where there's a good chance that they won't have indications for post-operative adjuvant treatment. So in patients that have a low nodal burden of disease without any obvious extranodal spread of the tumor within the lymph nodes, and also with the tumor being located in an area where it would be resectable without too much morbidity.
So you are in a very specialized, highly specialized area of head and neck cancers. How common these cancers are?
very common in my world, but it's
In the
more
population, like,
right.
what is the frequency that
I
or
think
prevalence of this
right.
disease?
I think it depends based on all the types of cancers. For example, thyroid cancers can be very common. Thyroid nodules are certainly very common. In terms of head and neck cancers, that again changes. There's more awareness now, but not uncommon, I
So
would
what are the
say.
risk factors? If somebody is watching, I'm like,
Right.
okay, well, how can I prevent that? When we talk to other surgeons, like heart surgeons, they can say, well, this is how you prevent heart disease. How do you prevent head and neck cancer?
Right.
Can
So
you?
I think so, which is a good thing. Smoking and drinking are certainly known, well-established risk factors for head and neck cancer. And also being aware. So going to your dentist, getting your mouth
I hate going
checked.
to my dentist, but that's okay.
And I think just the general awareness, so that if you're noticing a sore spot on your tongue, don't ignore it. If you're bleeding, if you're losing weight, if your swallowing is affected, your voice changes, get it looked at.
So did we see an increase in the survival in these kind of diseases over the years? Have we been able to change the outcome or the life
I would say
expectancy?
for sure, because number one, I think detection is also faster as more people are becoming aware, and there are less smoking is becoming less prevalent as we move on. And also with the advent of certain surgical techniques like the robotic surgery, and also there's been so much advances within systemic treatment, immunotherapy, and I think we've seen a much improved, we've seen improvement in survival for sure.
Fantastic. So tell me a little bit about, how difficult it is for, women to get into this field. I mean, I actually think that maybe it's a very delicate field, at least I would imagine. But
Right.
what is your perspective?
I personally, as someone who enjoys and really likes reconstructive surgery, so that's the aspect of surgery that actually got me into head and neck surgery. I think it is a very big, open, gross, as you would describe it, surgery. But I do agree, I think it is very delicate. We're trying to restore the patient's senses, form, trying to optimize the aesthetics of this surgery. So I would wholeheartedly agree with you that it's a not so delicate, but yet delicate surgery. In terms of women entering this field, certainly historically and up until now too, within head and neck surgery, there are certainly more male physicians. But I think if you enjoy it and you have a passion for it, if you have a passion for it, then things will certainly work out.
So you say reconstructive surgery. What is the reconstructive part? Is it like sculpting, the face again or the mouth again? Well, what is it?
Right. So to put it simply, it's basically replacing all the missing parts. So there can either be soft tissue that's missing or bone that's missing because it's involved with cancer and has to be resected. So when there's soft tissue missing and it's a large volume, I'll borrow tissue from elsewhere in the body.
Where?
So
From where?
forearm, lateral arm, calf, thigh, maybe even the back, the latissimus muscle.
So you do that surgery?
Correct,
Okay.
yes.
So you harvest the tissue from elsewhere?
Exactly, yeah. And I can't just borrow the tissue and plop it up there. It comes with a set of blood vessels brought up and connected to blood vessels within the region. So it's like transplant surgery, but using your own body parts.
Wow. So tell us a little bit about the advancement in that. As, borrowing the tissue, I can imagine that can be a big surgery as well. Has this become more accurate and more precise and better results over the years?
For sure, I would say so. I think there's been a lot of advancements in the types of flaps. We call them free tissue transfer, free flap surgery that are used. So traditionally, radial forms were used a lot, but they're all of these come with donor site morbidity. So there's been better advancements on the types of tissue that you can use. For example, the lateral arm, where the donor site morbidity could be a little bit less.
So you take the skin and the fat and the muscle? What do you take?
So from the radial form, I'll take the skin, fascia, fat. From the thigh, sometimes I can include muscle. If I'm using the back muscle, sometimes I take it as a muscle-only
And where do you
flap.
take bone from?
So for bone, my go-to is the fibula, but sometimes I will use the scapula as well.
Okay, and then so after you harvest that, you connect it to wherever you place it. It's like a Lego thing.
It is.
And then do you need to go again to another surgery? How does it work?
So it's always used, or it's always planned out as a two-team approach. So I have my colleague, Dr. Moedin, who does the resections. While she's working in the head area, taking the cancer out, I'll be working on the other part of the body, preparing the flap tissue. And once everything is taken out, we take the tissue, cut the blood vessels, bring it up there, and then I'll connect the blood vessels to blood vessels in the neck area. And we close the patient up. They stay in the hospital with us for about a week with very close monitoring, and we go from there.
Wow, that's amazing. And do you do these things in trauma as well, or only in cancer?
Certainly, these type of surgeries are described in trauma patients, burns patients, but I only work with the head and neck cancer patients.
Cancer, okay. And then let me ask you about the immunotherapy that you just touched on. This has been a huge advancement in medicine in general, but in your field, what kind of cancer has really changed, in the prognosis, in the cure rates,
right?
Due to immunotherapy?
Right. It is certainly a hot topic within head and neck cancer surgery. So the immunotherapy would be carried out by my medical oncology colleagues, who I work very closely with. But certainly there has been advancements with that within head and neck cancer patients as well.
So what type of cancer you can...
Squamous cell carcinoma.
Squamous cell, okay.
Yeah, so sometimes we'll do pre-surgery, so neoadjuvant treatment in the form. And there has been also studies shown that if we treat the patient with immunotherapy prior to the resection while the cancer is still present, it may subsequently decrease the risk of recurrence later on.
And these patients, they are older, younger, all ages, women, men? Give us what is the prevalence there?
My usual patient population would be someone who is elder and male. There's more male patients within the head and neck cancer population, but certainly we get all different types of people. So we do have our women patients. We do have the younger patient populations who, without any pinpointable risk factors, unfortunately develop cancer.
So let me ask you about the aspect of, the older male patient. Obviously, you look very young and you're not a male. Do you feel that you have the trust of your patients, or how do you gain it?
I think when I first started, it's something that I certainly talked about because I do get those comments from patients asking me how old I am, how many have you done? But I think once you start building that rapport, start explaining to patients counseling them through their diagnosis and explaining their treatment plan, you are able to build rapport and gain trust.
You don't need to bring another man in the room that says that she's fine? No,
not in 2025.
Okay, that's good. That's good to hear. That's fantastic. And so you train also people? You have fellows, residents? How does that work?
Right. So we do have our residency program. So we work with a group of residents. And being in the Texas Medical Center, a very unique environment, we have residents from other other programs that rotate with us. So we, at all times, have a big, sizable group of residents with us. And we also have a fellow within the department in facial plastics who will join me for free flap surgeries.
So in that arena of training, has this simulation environment developed? Because what you are describing to me is really almost a futuristic environment where you can reach unreachable slots through, ports that you insert different instruments and a camera, and you can work remotely, actually not near the patient, but in a kind of a remote environment where you operate the robot. Has the simulation also evolved? I mean, people can be trained better today?
I think so. The robotics, I've actually held a robotic course for the residents too, and that was in our Mighty lab. So we had the robot.
So Mighty, what is Mighty? Tell us a little.
All right. So it's the Research Institute with Houston Methodist with the beautiful facility and amazing space for labs and simulations, courses, huge manpower with resources, but they had helped us hold this course.
So what is this course? You led it?
I did, yeah. So we had residents come in, we had the robot, the machine come in, we had a model, we were able to simulate surgeries involving the oral pharynx, and the residents were able to learn how to set up the robot, operate the robot, and go through some modules.
Were you trained like that with a simulator or no?
There were a few instances, but I would say I learned mostly from the job.
So, okay, so also this environment is moving, right? Shifting from learning on patients in a real environment to a simulated environment. And you see that more and more.
Exactly.
It's awesome that you can hold these courses here at Houston Methodist.
Isn't it?
And is it only our residents or other residents are coming from all over the country?
We certainly have courses where there are larger groups of residents. This one was just for our residents and residents within the Texas Medical Center.
So what is the most difficult part to actually master the robot?
Oh, interesting. I think like any surgery, the setup is often the most difficult.
So tell us, what is a setup?
Right. So the setup involves, I guess, gaining exposure for the robotic instruments to be able to reach access. So it involves placing a device within the mouth to remove the bulk of the tongue, open the jaw so that you have the tumor in view.
And these surgeries take how many hours?
The robotic surgery, the robotic part itself, not too long. Once everything is set up, I would say maybe 1 to 1.5 hours. As in any cancer surgery, we'll send the specimen for frozen pathology to confirm clear margins. So that part takes a little bit. And then the robotic surgery, patients that undergo robotic surgery for oropharyngeal cancer often need a neck dissection too. So that adds a couple hours as well.
So tell us about your day. That sounds fascinating, but I'm sure people are kind of thinking, can I do that? I mean, what does it require?
Right.
Do you have a typical day? How does it look like?
It varies a lot. As you can imagine, all of my surgeries, all my surgeries range so much and vary so much in terms of how long it takes. I'll have a 30-minute case, and then when I'm involved with the free flap, then that can take anywhere from 8 to 12 hours for a difficult case. So my surgery days, huge variety. I'll usually within a typical week have 2 clinic days and then 2 designated OR days. But depending on what types of patients we see, we'll oftentimes actually move our schedules around to accommodate for our cancer patients.
So we keep hearing that there is a shortage of physicians, and it turns, I mean, as I'm listening to you, I'm like, wow, there's an incredible amount of training and expertise that is needed to become you. And probably as these diseases are kind of increasing, or more people are becoming more elderly because people live longer, hopefully smoke less, but live longer. Who is helping you? Is there an opportunity for non-physician clinicians to help you either in your clinic or in your surgery?
It is a team sport. So if we talk about the clinic and day-to-day life, we do have a head and neck PA who helps us tremendously.
Physician assistant.
Exactly. So he is so useful for coordinating our days, also communicating directly with the patients to deliver results, let them know of upcoming surveillance imaging studies, other appointments. We also have a head and neck cancer. We also have a cancer coordinator who helps patients navigate through their cancer treatment. We have an MA who helps us out in clinic as well. So it's a team sport in our day-to-day life too. But in the operating room as well, we could not do all these surgeries by ourselves. So we have our residents helping us, our fellows, we have a scrub techs, nurses. It's a
whole team working on this.
Exactly.
And then also there is another oncology team always, or radiation therapy team. So there's other teams too.
Correct. Yeah. So we have radiation oncology that works with us a lot. We have medical oncology. And to emphasize again on the collaborative nature of things, we have tumor board 3 times a month. Yeah. So it's a joint meeting that we have amongst the different disciplines who help take care of these cancer patients. So there's us, head and neck surgeons, radiation oncologists, medical oncologists, radiologists to help review imaging studies with all of us, pathologists who come to review.
So you discuss patient by patient by patient?
Exactly. So all of our head and neck cancer patients do get discussed at our tumor board, and collectively we come up with the best treatment plan for all of the patients.
That's fantastic. And that occurs every week?
We have it twice a week for our mucosal tumor board, so cancers within the aerodigestive tract, and then we have a cutaneous tumor board for cancers on the skin.
So every patient really benefits here at Houston Methodist from several expertise.
100%.
And then you look at the case even before you go to surgery and make a plan and then coordinate the plan.
Yeah.
So there's, and then you have to execute.
Exactly. And then after the surgery, we also rediscuss them to review their pathology slides and discuss their post-surgery adjuvant treatment.
So this is really fascinating. I think it's really the best patient care where you have all the specialties, different modalities, and then you plan the care, execute the care, coordinate the care, get the best result. This is really what we call leading medicine. It sounds like it's leading medicine. I wanted to ask you about clinical trials, what it is that we are doing here to give the patients opportunities to, try a new treatment. Who are these patients? How much are we involved? You are involved, your team is involved.
Right. So there are some trials with the medical oncology department looking at timing and types of different systemic drugs. Within the head and neck department too, we also have a trial that's actually running right now where we work with patients who have xerostomia after radiation treatment. So oftentimes, head and neck cancer patients, whether or not they undergo surgery, will require radiation treatment as well. And one of the side effects of radiation treatment is dry mouth. And it is very bothersome to the patients, affects their taste, oral health. They're often walking around with a water bottle because they constantly need to be taking sips of water. So we are looking at types of drugs that can help with xerostomia as well.
Okay, so we don't have a drug yet that is...
Not yet. We're looking at
because
different
that's something that many
modalities.
patients suffer from.
Exactly. So there are some drugs that may help, but there isn't a gold standard solution.
I wanted to ask you told me a little bit that you, before we started this webcast, you told me that you like art.
I do.
Tell us a little bit more about it. What do you like? What do you do? How do you have time to do it?
Yeah, so ever since I was little, I really enjoyed working with my hands. So doing crafts, painting, sculpting, things like that. So I think a part of why I enjoy reconstructive surgery so much and what drew me into it is the aesthetic nature of things, of trying to recreate form and function. So I enjoy painting, like I mentioned. I'll do acrylics, watercolor. I used to like oil painting, but that requires a lot of setup, so not able to do that a lot anymore. And timing-wise, I'm just starting to pick up more with it as now that I'm finished with my training, but it's hard to find time for sure.
Yes, but your work is a form of art, right? You're
It
recreating.
is.
One last question is really people sometimes think that reconstructive surgery is maybe cosmetic surgery, kind of confuse the two things. Can you just clarify what is cosmetic and what is reconstructive and how are they different?
Right. So reconstructive surgery in my world is very different from cosmetic surgery. It's actually necessary because we can't not do anything after, let's say, half of your tongue is resected or half of your mandible is taken out. So we need to, the big goal of reconstructive surgery is to restore form and function. So by form, I mean we need to rebuild your jaw. We need to add volume to places within your mouth or throat that are missing tissue. And then function, as in we want to make sure that the patient can eat, talk, swallow, breathe. So those are the main goals of reconstructive surgery. But having interest in art and liking to restore aesthetics of these reconstructive surgeries. Aesthetics is not something I take lightly during these reconstructive surgeries either. So I'll always try my best to try to make things look as nice as well.
Well, Dr. Laura Kim, this has been a fascinating conversation. I learned a lot today, so thank you so much for your time. And thank you for watching and see you next time.